Okay, I think it's about time. So the last time we talked about conscious proprioception, and the time before that we talked about pain and temperature. So today we're going to switch and we're going to talk about the efferent, some of the efferent system. In other words, how information gets out from your brain to go to your muscles to make you move. And so let's kind of at first think about the grand plan for our motor systems. And so when the idea goes off in your head that you want to move your finger, that idea starts in the frontal part of your cortex, prefrontal part of your frontal lobe. And so the idea starts somewhere in the front part of your brain. What's interesting is it then gets shipped to two very large subprograms. It's kind of like a computer program. One program goes to the cerebellum, which is a big, we talked about the cerebellum as kind of a second brain. And it then, regulates movement. It doesn't actually execute anything, but it's a subprogram that then sends information back up through the thalamus here. That's cerebellum. And then it eventually gets to the motor cortex, and then it gets executed. So this part right here is kind of the common piece of this whole diagram, which goes from prefrontal cortex area 4 down in what's called the pyramidal tract, that goes down to the alpha motor neurons in your brainstem and in your spinal cord that executes motion. The second pathway, the second subprogram, is called the basal ganglia program, and this program also takes its instructions from the frontal lobe. In other words, where you got the idea, it ships information back to the thalamus, common place here for information to go, and eventually it goes back to the motor cortex, area 4, prefrontal cortex, which then actually executes that instruction in movement. And so we divide the motor systems into pyramidal, which is the main one. That's the one that we're going to talk about first, the pyramidal tract. And then the extrapyramidal systems, which are the secondary systems, which are kind of important for some of the more patterned kinds of movement that we do. So there's pyramidal and extrapyramidal. Any questions about the grand plan? I also must mention that what we talked about last time, this sensory input here, this is the proprioception. Okay, so this is basically you're sensing where everything is with those 1A, the 1B, group 2 fibers. That is actually your brain is looking at where I am, and your frontal lobe is saying where I want to be. It's comparing those two, getting an error signal, and then it executes it on the pyramidal motor system. So sensory input is very important to the motor system. In fact, if you don't have the sensory input, from your muscle spindles and other proprioceptive fibers, then the motor system really gets very unstable. So that's a very important part of the system. Yeah.
What is that word to the right of pyramidal?
Pyramidal?
Oh, movement. Okay.
Oh, then you get movement. So the pyramidal system is a mammalian system. It's very simple. It's only 2 neurons that go from your brain to the executor, the alpha motor neuron. So it's not complicated really at all. Most of the neurons are quite large. They're all myelinated, or almost all myelinated, and almost all of them are in that pre-central gyrus, or in the gyrus that's right next to it. So pre-central gyrus, frontal lobe. There are two main tracts. The corticospinal tract, which is the main one, goes from the cortex down into the spinal cord. Now, if you look here, the name tells you where it goes. Corticospinal. It goes from the cortex to the spine. And the other one is the corticonuclear tract. It goes from the cortex to the brainstem nuclei for the cranial nerves. So the corticospinal tract is almost all crossed. That's why the left side of your brain controls the right side of your body. And so largely crossed. There are a few, maybe 10% that are uncrossed that we'll see in a minute. But that's why, if you have a problem with the left side of your brain, it affects motor on the right side of your body. And the corticonuclear tract is a little bit more complicated because the upper motor neuron that goes to the brainstem nuclei can either be crossed or uncrossed. And one particular, actually there's a couple of situations here that you should take notice of, and that is the facial nerve. For the lower face, it's only crossed. But for the upper face, it's crossed and uncrossed. And because it's crossed and uncrossed, that means that you can't get a paralysis of your face if you have an upper motor neuron lesion. And so if I have somebody that has a facial paralysis and they can't show me their teeth or they can't lift the eyebrows, okay, that can't be an upper motor neuron lesion. It has to be an end nerve problem because the upper part of the face has bilateral innervation, crossed and uncrossed. Okay? The hypoglossal nerve is only crossed just like the rest of the other spinal nerves, and the spinal accessory nerve is only uncrossed. And so that kind of interesting fact about the way those work. Now I like this diagram because it kind of shows where the neurons go. And so these are what are called upper motor neuron. It's only two neurons. There's an upper motor neuron and a lower motor neuron. But I'm going to trace the upper motor neuron from the precentral cortex. So basically this area right here is the motor strip. That's area 4, the precentral sulcus part of your brain. These fibers all come and they come like this, and they go through the most anterior part of the posterior limb of the internal capsule. So they kind of get bunched up together here. So they're all basically coming from the top of your head going down. If you remember, the internal capsule kind of looks like a V, and this is the most anterior part of the posterior limb of the internal capsule. They even get further compressed in the cerebral peduncle, so they kind of all get together right here. They fan out somewhat in the pons. We'll trace this in a minute. And eventually they go down through down into the medulla, where the vast majority pass over into the lateral corticospinal tract on the other side. So the point of crossing of these fibers is in the medulla. Okay? So anything that affects the spinal cord, is going to end up with a motor defect on the same side if it's below the pyramidal decussation. So anything that affects corticospinal below the pyramidal decussation is going to affect that same side, whereas anything that affects the cerebral peduncle, the pons, the mesencephalon, the internal capsule, it's going to have a contralateral motor defect. Okay? Again, it's very, very simple. You basically have the precentral gyrus, which is that big part of the frontal lobe. So the cell body is here. This is your cell body here, these big cells. They go all the way down through the mesencephalon, down into the medulla, and then they cross over to the other side. And so your upper motor neuron is going to be continuous all the way down through the pyramidal decussation. It's going to go into the lateral corticospinal tract, and then your second order neuron for motor is going to be in the anterior horn of your spinal cord. So we have an upper motor neuron. This is upper motor neuron, and this down here is called the lower motor neuron. So there's only two. Upper motor neuron, lower motor neuron. They cross at the pyramidal decussation. Any questions? Okay, and so it turns out that your brain gives a very large amount of real estate to your hand, and so our hands are real important to differentiate us from a lot of other creatures. and we get a lot of innervation for our face, and that's mostly involved in speech. And so we have our hand and our face that get a lot of representation up in our cortex. The trunk gets relatively little real estate, and your foot gets relatively little real estate. That's where the cell body is, that is the upper motor neuron that makes you be able to move. So let's kind of follow this on some cross sections. And so I'm going to start at the level of the, this would be at the level of the pons, and the motor fibers are dispersed here. And so the motor fibers are going to be these fibers right here. This is the pyramidal tract, or the corticospinal tract. They're kind of dispersed. This is the fourth ventricle here. As we go down a little bit, the motor fibers get more concentrated. So this is the place where you have the motor fibers right here, the pyramidal tracts. Okay. So this is where the fibers are. Just to give you some other landmarks, we're going to be talking about this shortly, but this is called the inferior olivary nucleus. This is the middle cerebellar peduncle, or the brachium pontus. And this is the inferior cerebellar peduncle. These other nuclei are actually cerebellar nuclei, and this is the fourth ventricle. So kind of tell you, we'll talk about those later. So you can see that the inferior olivary nucleus is quite large here. The pyramidal tract is right here. This is the motor tract. Now at this point, it is uncrossed. We're still up high in the medulla. So this is anything that gets affected here is going to give you a motor defect on the other side. We have not gone through the pyramidal decussation yet. Then we go down a little farther. Okay, this is the main corticospinal tract, or the pyramidal tract. We're down now into the upper part, or middle part of the medulla. And these are some nuclei we talked about last time. This is the gracile, and this is the cuneate nucleus. This is where proprioception synapses. This is the first synapse for proprioception, right before the internal arcuate fibers. And then as we go further down in the medulla, you can see here, this right here is the pyramidal decussation. So the pyramidal fibers from this side are moving over into this location and into this location, which is now basically are going to be corticospinal tract on the same side from that point on down into the spinal cord. And again, you can see these very large gracile and cuneate nucleus for proprioception. Okay, so again, real simple. You just need to kind of get the idea. Upper motor neuron, lower motor neuron, crossover at the pyramidal decussation. So there are big differences, though. If you destroy or hurt the upper motor neuron or lower motor neuron, either one, you're going to end up with a paralysis. But the kind of paralysis you get is quite different. And so an upper motor neuron lesion is going to produce a contralateral, opposite side hemiplegia. So basically you become paralyzed on the opposite side. So you lose fine movement primarily in your hands, in your face, because that's where you get the largest amount of representation. And so if you have, like for example, a stroke that affects the cortex gives you paralysis on the opposite side. Okay, it starts off as being paralysis and hypotony. In other words, there's not much muscle tone. So basically it's kind of a flaccid paralysis for at least a day or two. Now what's important is that after a while you begin to get spastic. So with an upper motor neuron lesion, although you start off with hypotony, after a few days you end up with a very stiff spastic paralysis. You can't move your arm, can't move your hand, but you're spastic. You have increased muscle tone. And the reason is because the lower motor neuron is still very much intact, and so you're getting all of the the tone from your lower motor neuron, which has now been released from the influence of the upper motor neuron. And the other thing that happens is that after a few days with an upper motor neuron lesion, you begin to get an accentuation, an increased in the deep tendon reflexes. And so if you do the test on the tendons, you'll see that not only do you have a brisk reflex, but it becomes so brisk that a lot of times it just oscillates. And so, for example, if I did a test on my biceps, I would do like this, but not only with that, my arm would continue to move. So the deep tendon reflexes become hyperactive, okay, and if they keep moving, that's called clonus. So you accentuate the deep tendon reflexes, and then there are some classic, we call them release reflexes. And I'm going to get Kaylee to come down here. Kaylee, come on down. Miss Boswell has agreed to be my patient today. So I'm going to demonstrate one of these reflexes, which is called, this is actually the most important reflex. Come on over for a minute here. Okay. So what I'm going to get you to do is I need you to lie down here and put your foot over there towards that chair, okay? And I'm going to get you to take one of your shoes off. And your sock. So the Babinski reflex, the way we do this is what I like to do is just with a key. I always have a key in my pocket. Okay? And so the idea here is that ordinarily, I don't know if y'all can get on the other side here. I'll move around. I need you to lie down. Play like you're, now this only works if you're comatose. So put your other foot up here. Right. And so if I take my key and I stroke her foot, now watch. I didn't touch you yet. Just relax, okay? Now if I touch her foot, do you see how the toes curl down? Y'all see that? Watch. See how they curl down a little bit like that? And to really do this, now, you only do this on somebody that's, really kind of comatose, but the idea is with the key, you want to create excruciating pain. I'm not going to do that. Anyway, if I stroke her foot, and now Kaylee's she's in a coma. She's had a stroke. Okay, that's the upper motor neuron, right? Upper motor neuron. Now instead of that, see that down reflex of the toes, how they curl when I stroke her. What happens when I do this is the toe goes up and the other toes fan out like this. Okay, it's also called the upgoing toe reflex. And I'll demonstrate it here where everybody else can see it. So ordinarily, again, we'll hold this back so the rest of the class can see. Ordinarily, the reflex is to curl down. You actually curl down into the reflex. But if she had upper motor neuron lesion, okay, the big toe would go up, and these other little toes would fan out like that. And it's called the Babinski reflex. It's one of the release. It's a release phenomena when you have an upper motor neuron lesion. Okay, you did good. Yeah. Give her a good hand. Any questions about the Babinski? There's also a Hoffman reflex, but the Babinski is the classic for the upper motor neuron. That's how you become spastic, you're paralyzed, you have a Babinski reflex, you have an upper motor neuron lesion. That helps you to tell where the problem is. It's like a puzzle. When we do clinical medicine, you're always trying to solve a puzzle, right? Okay. The other thing is, because the lower motor neuron's fine, you get no muscle atrophy. So you're paralyzed, you're spastic, but you get no muscles remain normal in terms of their mass. So they're not, your brain can't control them, but the muscles don't atrophy. Now in contrast, a lower motor neuron lesion, if you have a damage to your spinal cord, you have a flaccid paralysis on the same side, right? Because if you do something to the spinal cord, you're basically destroying the alpha motor neurons that come out on the same side. So same side paralysis also starts off as flaccid, but it stays flaccid. And after a few weeks, the muscles begin to atrophy. So this is one of those really kind of weird things about physiology, in that the muscles have to be innervated in order for them to stay alive. And so if you destroy the spinal cord or the lower motor neuron, once you destroy that, the muscle cells that they go to, simply because you destroy the neuron, the muscle cells will die. They go away. And so you end up with muscle atrophy, and in the process of the muscles becoming atrophic, you actually get what's called deinnervation supersensitivity, because you have a little bit of acetylcholine that circulates in your blood. What happens is the muscle cells just sporadically get enough acetylcholine where they'll just spontaneously contract in a non-useful way. Your brain's not control it. So basically you get, your hand doesn't move, but if you look at your muscle, it'll have like little worms, it'll kind of wiggle. Those are called fasciculations. And you get kind of a characteristic electromyographic kind of appearance too. So the way that these are treated are completely different too, because if you have an upper motor neuron lesion, you actually have to do physical therapy to treat the spasticity. So you have to go to a rehabilitation clinic where they work with you to try to keep you from getting frozen in one position, because you're spastic. You're paralyzed, but you're spastic. You don't want the joints to become non-functional. So basically you have passive range of motion exercises and other things to rehabilitate. On the other hand, if you have a lower motor neuron lesion, the idea here is that if indeed it's say a peripheral nerve cut, you basically want to tide the patient over until the nerve can repair itself, because a lower motor neuron lesion, if it's outside the dura, it'll repair itself. And so in that case, you might do functional muscular stimulation. You might artificially electrically stimulate the muscles to keep the muscles alive. You want to basically preserve the health of the muscles so that when that nerve does repair itself, you'll be able to regain some motor function. So they're treated differently. Any questions? That's the pyramidal motor system, also the corticospinal tract. Yes. What causes what?
The lesions.
Lesions? You mean for the upper and lower?
Yes.
Yeah, well, the upper motor neuron is typically a stroke. I mean, that's usually what knocks out the upper motor neuron. You can get lacunar infarct with diabetes. It only takes a very small, if I back up for a second here, kind of remember how this works. So you have a stroke. Well, this is in the distribution of which artery? This is the middle cerebral artery. It's also, the classic, kind of stroke where you just end up, with sudden paralysis of half of your body. And that's usually because of a blood clot in the middle cerebral artery. So basically you knock out the motor strip. You become ischemic, and, those cells eventually, will die. Now, the other place where you can get really, really bad things that happen is where these fibers are really, really close together. And so you can get a very small infarct in the internal capsule or a very small infarct in the cerebral peduncle, and you'll end up with a profound paralysis. And this can happen a lot of times happens with diabetes, which is a small vessel disease, where it just takes a very small lacunar, just a very, very small area that's actually infarcted, will give you a very profound paralysis on the opposite side. Okay, so anywhere you affect, the corticospinal tract, before you actually get to its termination, either in the bulbar nuclei or in the spinal cord, anywhere you affect it, you're going to get a paralysis. How bad the paralysis is depends a little bit upon the placement, how close the fibers are kind of packed together. So that's the upper motor neuron. For the lower motor neuron, there are certain diseases that kill the lower motor neuron. The prototypical example is polio. So poliomyelitis, viral infection, will go in and target the alpha motor neurons, and you kill the lower motor neuron. But you can also kill the lower motor neuron with an ischemic event, or you can kill the lower motor neuron or knock out that second part of the final common pathway. You can knock it out if you have any kind of a cut to the peripheral segments or the peripheral nerve. And so if you're get accidentally cut with a knife, or if you're in a car wreck and glass cuts your arm or something, you cut one of your nerves, you have to put the nerves back together. You suture them back together in some kind of a growth channel so that they can reconnect. But being a peripheral nerve, it'll actually reinnervate. It'll actually grow back together, whereas the upper motor neuron really doesn't. And so that's why spinal cord injuries, can be so devastating, because they don't typically, reconnect. They don't go back together. Yeah.
For the peripheral nerve, how long will it take for them to reconnect?
It depends on how much is affected. So if you just have a clean cut and you put the two ends of the nerve together, they can reconnect in a week. If you have a segment of the nerve which is crushed, and you actually have to have the nerve go through a kind of a growth chamber to get back to where it can reconnect, it can take several weeks, which is why you have to do the functional muscular stimulation to keep the muscle alive while the nerve is reconnecting. We had a professor here, Christine Schmidt, has done a lot of research. She's now she left UT about 5 years ago. She's now the chair of the Department of Biomedical Engineering at the University of Florida. But you might want to, if you're interested in how to do nerve growth reconduits, and there's certain things you can do by making a kind of an artificial scaffolding with nerve growth factor that promotes the nerve to kind of regrow back together. But Christine Schmidt, SCHMIDT, would be a good person to look up about that. Any other questions? Okay, all you ever wanted to know or needed to know about upper motor neuron disease. Now the second part is a little bit more complicated, unfortunately. And this is called the extrapyramidal system. And so you probably realize that if you have a stroke and you knock out the pyramidal system, you really can't use your hand very well, and a lot of times you can't speak very well because that gets represented, highly in the pyramidal system. But with rehabilitation, after a few months, you actually regain some motor function. Most people that have a stroke, with rehabilitation and practice and learning, can relearn how to at least walk. You don't have fine motor, but you can relearn how to walk. And a lot of that has to do with this extrapyramidal system. And so this is another system that goes through the basal ganglia. If you remember the basal ganglia, they consist of the caudate, the putamen, and the globus pallidus. Those three nuclei taken together are called the basal ganglia. Okay, and so these project down into some other pathways which are extrapyramidal. They don't involve the same pathway that we just talked about. And so the extrapyramidal system is primarily the basal ganglia, the substantia nigra, subthalamic nucleus, the red nucleus, the reticular formation, and the vestibulospinal tracts. We talked the last time about the kitty cat, that has the brain cut off, and you can throw it up and it'll always hit on its feet. And that's because of these extrapyramidal systems. Specifically, it's the vestibulospinal tract that allows you to be able to have some basic kind of orientation and motor, even in us humans, if you lose the upper influence of the cortex. Okay. So the first one we're going to look at is called the rubrospinal tract. Again, look at the way that it's written here. Rubro, red, rubrospinal. It goes from the red nucleus in the diencephalon down through the mesencephalon. It crosses, and then it eventually goes, so it's a cross pathway, it eventually goes to primarily the flexors in the upper extremity. It's somatotopically organized. So here is the origin of the rubrospinal tract. This is the third ventricle here. This is the thalamus. Okay. Here is the red nucleus. Okay. Substantia nigra, which we're going to talk about in just a minute, is right down here. And so this is the place of origin, the first cell in this pathway. So red nucleus. It doesn't usually go down to your feet. It kind of terminates in the cervical cord. And like I said, it's usually really more to the flexors in your arm and your hand. Basically, we have a cortico-rubral tract, and we also have a cerebellar rubral tract that are afferents that actually go to the red nucleus that help to regulate its activity. But just the thing for this class is basically it's excitory to flexors in the upper extremity. The reticulospinal tract is divided into two branches. There is a lateral reticulospinal tract, which starts in the medullary part of the reticular formation. So this is in the medulla, this is in the brain stem. Has both crossed and uncrossed fibers. And then there's a medial reticulospinal tract. So again, the name tells you where it goes. It goes from the reticular formation of the medulla. Okay, that's the lateral reticulospinal tract. And it terminates on the alpha motor neurons, lower down. And more importantly, these tracts, a lot of these project to the gamma motor neuron system. Now remember, the gamma motor neuron system is the system that regulates the tension in the muscle spindle. Remember last time we talked about the muscle spindle as being really kind of unique in that you've got these little tiny muscles which are also sensory receptors that are in parallel with the main motor fibers in your musculoskeletal system. Well, this system projects down into that gamma motor neuron system, and because of the amplification that you get in the monosynaptic stretch reflex, remember that's the reflex that goes from 1A directly back on the alpha motor neuron. Okay, remember that one? Okay, I can put just a little bit of gamma motor neuron input in, and I can regulate the state of contraction. I can regulate the tension primarily in my legs. And so this is really important for posturing. It's important for posture. My brain doesn't have to be involved a lot, in terms of posture. All I have to do is to know that, this is up, this is down, I want to stand up, and that gamma motor neuron system can do that very efficiently. And so reticulospinal tract is largely a gamma motor neuron system from the medullary and pontine reticular formation down into the gamma fibers that are segmental level in the spinal cord. Okay. It also has some function in respiration, your kind of normal respiration, and in controlling the tone of your blood vessels. And then the vestibulospinal tract goes from the semicircular canals, which sense angular motion and position in space. In the lateral and medial vestibulospinal tracts, project ipsilaterally into the nucleus of the 8th cranial nerve. Remember, the vestibulocochlear nerve. And they go primarily to the axial and proximal muscles that are important for posture also. And so a lot of this is also gamma motor neuron input. And so you can see here you have your vestibular nuclei. So basically you have the 8th cranial nerve over here, which is putting input into this, which sends ipsilateral input down into the gamma motor neurons that go out to the different muscles. Okay? So those are kind of the extrapyramidal pathways that allow us to be able to maintain posture and be able to have some motor function, at least in the upper extremity, through the rubrospinal tract, even if you lose the pyramidal tract. Any questions about the major extrapyramidal systems? So the place of origin, is in the caudate, putamen, and globus pallidus. When we kind of pair these up, a lot of times the caudate and the putamen we kind of pair together, and we call that the neostriatum because it's a little bit newer on its evolutionary status. And the globus pallidus is a very old nucleus. It's present in our ancient ancestors. And so the basal ganglia is very important in regulating pattern motion. So things that we do repetitively, this is a subprogram that the brain just says, I want to do this, I want to move my fingers this way, and it'll automatically figure out how to do that in the most efficient way possible. So again, think of the basal ganglia as being a subprogram that's being addressed by the cortex. Yes?
Is this kind of what people are talking about with muscle memory?
Yeah, it is. I mean, this is motor memory. This is where one of the places, we're going to talk about two places where motor memory is stored. One place is in the basal ganglia. The second is in the cerebellum. If you go back and look at the very first slide from today, your two subprograms are basal ganglia and cerebellum. And so basal ganglia is one of those systems for motor memory. So remember that this is a diencephalon. You have kind of the caudate being very large anteriorly, and eventually it forms this tail which kind of curves into the temporal lobe. And then you have the putamen and the globus pallidus, which are two structures that are very close to the lateral ventricles. And so, this actually isn't terribly hard to understand if you just remember that there is no primary outflow pathway for this basal ganglia system. So basically you're getting instructions from the frontal lobe, and these instructions from the frontal lobe come down into the neostriatum. They come down to the caudate and the putamen. And then the outflow all goes through the globus pallidus. The globus pallidus is a processing outflow place, and then all of the output eventually goes into the ventrolateral thalamus. Okay, and the ventrolateral thalamus goes right back up to the cortex. So we've got information flow in and information flow out, but there's no execution. Where is the execution? Andre? There's no execution. Information is coming from the cortex, gets processed in the basal ganglia, goes through the thalamus, and it goes back up to the cortex. Where's the execution? The execution is by the pyramidal tract. That's the one we talked about first. So all that this is doing, and one way to think about this, is kind of like an ice sculpture. So you can think of motor as being kind of coarse and crude, and what this does is it kind of chisels away at the motor function, these motor instructions, to make it a beautiful sculpture. It makes it a nice pattern, beautiful, smooth motion, as opposed to something which is very jerky and not precise. Okay? So again, think of this as being a sub-program. This is an important diagram that you pretty much need to memorize, and basically it shows the same thing. And so you have all of these inputs. These are all inputs here. Every bit of this is input from the brain, primarily from the frontal lobe. All goes to the caudate and the putamen. Okay, information gets passed into the globus pallidus. And there are two other little modifiers here. One is the subthalamic nucleus and the other is the substantia nigra. Now the substantia nigra is real interesting. It actually is a inhibitory subcircuit. The substantia nigra has input from the neostriatum, but it also has a feedback system which goes right back to the neostriatum. It also has an inhibitory pathway which goes up to ventrolateral thalamus. And so the substantia nigra has primarily like I said, it's like an ice sculpture. It actually is taking away, it's sculpting, it's actually decreasing the activity. And so the substantia nigra and the subthalamic nucleus are all part of this kind of big circuit. Anyway, the outflow here is called the ansa lenticularis. Okay, and the output from the basal ganglia all goes back to ventrolateral thalamus, which then sends it right back up to the cortex. There's no executor. There's no execution path. Execution is where, Andre?
Pyramidal system.
That's right, the pyramidal motor system. So basically it's sculpting what happens on the pyramidal motor system. Questions? This is a little more detailed diagram. It shows this exact same thing. Your cortex is sending signals. This is the inflow pathway into the caudate and the putamen. This gets shipped down through the internal and external segments of the globus pallidus, and you basically relay all this information back up to ventrolateral thalamus, and this goes right back up to the cortex. Now there are a few other little minor details here in that I didn't tell you the whole story here, in that you do have a very small gamma output here, which is going down in the gamma motor neuron system, but that's usually for more postural things as opposed to fine movement kinds of things. This is a little circuit that kind of shows the effect of the substantia nigra. And so here is the substantia nigra here, and you see that it gets input from the neostriatum, but this cell right here is an inhibitory cell. So this is an inhibition, which then passes back up to the thalamus, and then it goes back up to the cortex. So basically this is an inhibitory input. It's limiting oscillations, it's limiting excuse me, unwanted motor function. So it's basically chiseling away at our ice sculpture. Okay, that's the effect of the substantia nigra. And so, this is another diagram which shows the same thing. All of these are the same. Inflow from the cortex, putamen here in the caudate. Basically, it all ends up going back through the globus pallidus, and eventually you have all of the output going back to ventrolateral thalamus, and then it goes back up to the cortex. So just one big kind of a feedback circuit. Okay, any questions about the circuit before we talk about some diseases that affect the basal ganglia? Okay, have you all heard of Parkinson's disease?
Yeah.
Anybody here known somebody who had Parkinson's? I'm sorry?
My grandpa.
Grandpa? Okay. So age certainly plays a role. Can you get Parkinson's at an early age? Absolutely. You can get Parkinson's when you're age too. In fact, there was a real interesting epidemic of Parkinson's. In fact, the way we study Parkinson's is actually because of an epidemic of Parkinson's disease, which is caused by a bad bunch of heroin, okay, which was on the West Coast. And so there were a bunch of young folks, in their teens and 20s that used this bad heroin. And within a week, they all developed terrible Parkinson's disease. And actually, that's the animal model. I mean, we don't do it human, but the animal model that we use now in monkeys, we basically use the same bad stuff to create Parkinson's in monkeys, and that's how we study it. So, kind of an interesting historical. But your grandpa, probably a little older. So what causes Parkinson's? Really don't know for sure. There was a large outbreak of Parkinson's. About 1 to 10 million people got Parkinson's disease after the flu pandemic, and right after World War II, there was a terrible pandemic of flu. There was whatever strain it was just horrible, and almost everybody that had the flu ended up with some kind of Parkinson's disease. So I mean, your grandpa, I don't know how old he was, but I mean, could have possibly maybe had the flu. I mean, we think that other things, we think that probably pesticides, exposure to environmental toxins might play some role, perhaps in Parkinson's. There's some epidemiological evidence that happens. But it affects a lot of people. Anybody else know anybody with Parkinson's? Yeah.
My uncle has it. He's in his 30s right now, so.
He's what?
He's only in his 30s.
He's still in his 30s? Okay. So it can affect younger people too. Don't have to be old. But it typically, is more in older folks. Anybody else? Yeah.
My journalism teacher had Parkinson's.
Okay.
Fairly advanced, but he was still teaching. He was having like a lot of spasms.
Have the motor disorder? Okay. So it's really common. I mean, you'll know people, if you haven't already, you'll know people that have it. There are about 50,000 cases in the United States that are newly diagnosed every year. Mostly older folks, but it can happen, if you're younger. And we know that what happens is you lose dopaminergic cells in the substantia nigra. Substantia nigra, when you do a brain dissection, it actually looks black. That's why it's called substantia nigra, black. And so you lose your dopamine cells. And because of that, you lose the inhibition, that goes back through ventrolateral thalamus back up to the cortex. You don't get symptomatic until you lose about half of the cells in the substantia nigra. And again, we don't know exactly why, most people get it, but there certainly are associations with flu-like illness, certain environmental toxins, pesticides, and certainly age makes a difference too. So, what are the symptoms? How do you tell if somebody has Parkinson's disease? So the first thing you get is what's called a pill-rolling tremor. So watch what I'm doing here now. So somebody has Parkinson's, they have a resting tremor, okay? And the tremor goes away if they do something. So they can move the motor when they do that, it goes away. But if you look at somebody with Parkinson's, you watch when they're not doing really any useful motor function, and they'll sit there like this. Pill rolling tremor, like this resting tremor. Have you ever seen somebody like that? You can go to the grocery store. A lot of times if I go to the grocery store, I just kind of like to watch around. You can see folks, you can tell them real quick if they've got it. They're like this. Okay, resting tremor. You also become stiff. You basically become more rigid. A lot of times you have an expressionless face. Everything is slow, bradykinesia. Every bit, all the motor function is slowed down. And typically somebody with Parkinson's, they walk kind of stiff and they kind of walk like this. If you watch somebody, it's kind of like this. Okay, that's Parkinson's. All right? Y'all know what I'm talking about? Have y'all ever seen somebody like that? No? Y'all don't watch. Well, anyway, those are the symptoms. That's the symptoms of Parkinson's disease. Any questions? Okay. So why do you get Parkinson's? Maybe cell stress. We know by studying people's brains that have Parkinson's that does involve misfolded proteins. People that have advanced forms of Parkinson's get intracellular inclusions, which are called Lewy bodies. They're intracellular clumps of protein. And we know that probably has something to do with not only the misfolded proteins, but perhaps a defect in the chaperone system, which is ordinarily supposed to take unfolded proteins and get them back folded into their functional form. And so it could be either that there's either too much of the misfolded proteins, or the chaperone system's not working, or you can't eliminate the abnormal proteins through the ubiquitin proteasome system. And anyway, the cells die, so you end up with loss of cells in the substantia nigra. And so that's what causes the motor defect in Parkinson's. We know that there are at least two genetic mutations. One is a mutated alpha-synuclein protein that folds incorrectly and probably accumulates in these Lewy bodies. And we know that there's a second form with a mutant Parkin protein, which causes a failure of the ubiquitin system to dispose of the abnormal proteins. So how do you treat Parkinson's disease? Well, the standard of treatment is treatment with a precursor to dopamine that actually crosses the blood-brain barrier. So if you just give somebody dopamine, you'll rev up their heart, but it won't get into their brain. So you have to give a precursor which is taken across the blood-brain barrier. It's called levodopa, L-dopa. Okay? And that increases the amount of dopamine that's available for that pathway, that inhibitory pathway that goes from the basal ganglia down to substantia nigra, back up to ventrolateral thalamus. So maybe y'all have read about, maybe, is anybody here doing a research project for the class on Parkinson's? No? Yeah, you are.
Our group is doing Parkinson's.
Y'all are studying Parkinson's? So y'all have some treatment options? What?
Yeah.
Yeah, well, speak up. So what have y'all discovered so far?
A deep brain stimulation is our key one that we're looking at.
Brain stimulation.
Deep brain stimulation.
Okay.
Carl's the one that's been doing this research. So he is the expert in our group on this.
Who's the expert?
Carl.
Carl. Where's Carl?
I don't know.
Speak up. Speak up, Carl.
Well, that was awkward.
Not in class today.
I want to know about how.
Bad Carl. Okay, we caught him.
There's been a bug going around. You might be sick.
What?
You might be sick. There's been something going around.
Oh, there's something going around? The flu or what?
I don't know.
Some viral illness? Gastrointestinal or respiratory? Respiratory. Okay, so deep brain stimulation is one possibility. And so, interestingly here, most of the deep brain stimulation is actually for the thalamus. I don't know if y'all figured that out yet, but so you put a Medtronic. Medtronics makes a deep brain stimulator. You implant the electrodes in the thalamus, and you can inhibit that thalamic circuit by stimulating actually the thalamus. So that's certainly one possibility. And for intractable cases that aren't responsive to L-dopa, I mean, that's certainly one option. How about stem cell transplants? Y'all talked about that?
Not.
Okay. Interestingly, so do you know where most of the stem cell research on this disease came from? It came from actually down in Brazil, if you look at the literature. And so there was a group, they probably have a little more lax regulations. The FDA probably not as active as it is here in the United States. But basically what they did was they took cells from the adrenal gland. Okay, so your adrenal gland makes epinephrine, right? Okay, so a precursor to epinephrine is dopamine, right? Okay, so you take cells, these were people that had really bad Parkinson's disease, they just took a little bit of tissue out of the adrenal gland and they implanted it up in the brains of these people that had Parkinson's disease, and remarkably they all got better. I mean, like 100% cure rate, and the whole community, the whole research community thought, wow, we got a cure here. You know, it's doesn't have any issues, you know, with fetal tissue. You basically just take an autologous transplant, adrenal gland tissue, put it in the brain, it makes dopamine, and people get better. Why don't we do that now? I need Carl. Well, it turned out that everybody, after a short period of time, they actually got better. But after a short period of time, everybody went back and they were as bad or worse than they were to start with. Okay, and part of it is that if you do some kind of a stem cell transplant, you haven't removed whatever it was that was killing the cells to begin with. You have to ask yourself, well, why did the cells die in the first place? And if I go and put some new cells back in, what's going to keep them from getting killed by the same thing that killed the cells that were normal to begin with? Okay, so you know, it treated some of the symptoms, but it didn't get rid of whatever it was that was causing the body to kill the dopaminergic cells that are in the basal ganglia. So, I mean, other things where people are looking at research or gene therapy. Maybe if we knew the pathway better, we could increase the chaperone activity. Glial-derived neurotrophic factor has shown some promise in treating people that have Parkinson's disease. So, but still a really, really bad problem that really does not have a cure. The problem with L-DOPA is even though you get a response early on, that response wears off. I don't know if you ever saw the movie Awakenings. Did y'all ever see that movie, perchance?
Yeah, it was horribly depressing.
Yeah. So what happens is the therapeutic window. So you start off and you get a great response, but that therapeutic window gets narrower and narrower and narrower the longer you treat, see, with the L-DOPA. So all the time you're having to go between being stiff, rigid, and then being so active you get these tardive dyskinesias. So the therapeutic window is not real big. Yeah.
When I was doing research for the project, I read that there's an inverse correlation between smoking and developing Parkinson's. Is that true? Or
I hadn't read that. Smoking cigarettes or pot?
Cigarettes.
Okay.
Apparently,
Maybe nicotine. Maybe has a protective effect, I think. Yeah. I don't know. Line of research to pursue. So, again, you know, this is kind of that idea that, you know, we create these proteins, they probably aren't folded right, so we basically have these chaperones that fold them, and if they fold them correctly, then we have a functional protein. On the other hand, if we don't fold them correctly and we get an accumulation of these abnormal proteins, we have this system which tags the abnormal proteins with ubiquitin, and then the proteasomes digest the proteins and get rid of them, but you know, break them down to amino acids, and then they're not toxic. And so again, the two mechanisms that we just talked about are you have either a defect in the ability of the cell to tag the abnormal protein so that the proteasomes cannot degrade it, and you get these abnormal proteins that accumulate. They make Lewy bodies, which actually are probably protective. So when you get these abnormal proteins, the cell's trying to clump them together to where they don't cause as much damage. Fact is, there are a bunch of studies that show if you don't let them clump, it actually is much more toxic than if you let them clump, but eventually they'll kill the cell. Or, you know, you could have this abnormal Parkin that, you know, causes, again, the accumulation of these unfolded proteins, and they cause the cell death. And actually, there's a lot of similarity between this pathway and some of the other neurodegenerative disease. So this is not just necessarily just for Parkinson's. Okay, so there's some other diseases that produce abnormal motor function. The first one we're going to talk about is called Sydenham's chorea. Okay, chorea means a dance form motor defect. So this is a defect. If you see somebody like this, it typically affects their arms. And so somebody that has a choreiform movement is going like this. It's uncontrolled. Okay, like this. It's a choreiform motor defect. Okay. We know that the Sydenham's chorea occurs as a part of the rheumatic fever syndrome, which is post-streptococcal. So the next time you get a sore throat, just remember that if you get sore throat, you've got 1 in 500 chance of getting rheumatic fever. And if you have rheumatic fever, you have a 20 to 30% chance of getting Sydenham's chorea. So just a reason why you should go to the health center, get penicillin early on, okay, because it's 100% cure, right? So this, we know exactly what causes this. This is post-infection with group A beta hemolytic streptococcus. Common infection. Anybody in here ever had strep throat? Okay, you see how common it is? Anybody here ever had or known somebody had rheumatic fever? Y'all? Yes.
My mom did when she was little.
Okay, and what happened to her?
She ended up being hospitalized for almost a year.
Almost a year. And so, what happens with rheumatic fever?
The infection spreads, and she had lung and heart issues.
Right. It causes a carditis, and so you end up with mitral valve, typically a mitral valve insufficiency. So a lot of people that have rheumatic fever end up with a defective mitral valve. Did she have that? Or she just had the carditis.
Mm-hmm.
She recovered. This is, again, that's part of the rheumatic fever. The other thing you get is you get a rash. You get an erythema migrans. So basically you have this rash that kind of goes all over and you end up with arthritis. So it's a combination of carditis, arthritis, and the choreiform movement. So that's all part of the kind of rheumatic fever syndrome. Typically kind of starts not when you have the sore throat, but about 6 months after you have the sore throat. Females are a little bit predominant, and usually folks that get this are a little less than your age, but you can get them as an adult. Most people recover usually after 6 months, but some people, the symptoms will persist, particularly the valve problems and the choreiform movements can, persist. Again, penicillin is 100% curative if you get it early on. We use the benzodiazepines. We talked about that earlier. And we use Haldol or haloperidol to help control the motor defect. Those are two drugs that we talked about in an earlier class. Any questions about Sydenham's chorea? Yes?
Is rheumatic fever the same thing as scarlet fever?
Yes. Scarlet fever is the rash. So another choreiform disorder is Huntington's disease. Y'all heard of Huntington's disease or studied that? Okay, it occurs about 1 to 2 in 10,000 people, so it's not terribly rare. It's not terribly common. It's an autosomal dominant disease, so that if you have a parent that has Huntington's disease, you have a 50-50 chance of also getting Huntington's disease. Typically, the symptoms start when you're about 40 years old, and so you're past or you're well into your reproductive years. And remember, you don't have symptoms until you're 40, but if you have the gene, you're going to pass that on to 50% of your offspring. Okay, got the idea there? We also know that this is really there's a mutant Huntingtin protein, okay, which is misfolded, just like very similar to Parkinson's disease. And it affects primarily the caudate part of the putamen, which gives you the choreiform movement. And the bad thing is that from the time of onset, so you're perfectly healthy until you're 40, but then you basically are going to die in 10 years, and it's a very, very unpleasant death. You basically get a progressive dementia, and you get a progressive motor defect, which makes it to where you get stiff and you have these dance-like choreiform movements that are uncontrollable. Okay, so this is actually a disease which could be totally eradicated. If people that had the gene didn't reproduce, you could eliminate the disease within 1 generation, right? And so, let's play through some scenarios here. Pauline, let's suppose that your mom had Huntington's disease. There's a genetic test which is 100% accurate. And you're how old? 21. She has no symptoms, but her mom had Huntington's. Would you want to know? Would you have the genetic test? There is no cure.
I probably would. I actually shadowed a genetic counselor, and we had a problem with this where somebody had it and they didn't want to tell their children, or just because they knew they had 50% chance that they would have it, or I don't know. But I would probably do it so that I wouldn't have kids.
Only 5% of people that have a parent get tested. Did you know that? 95% elect not to know. There's a genetic test that'll tell you. But if you know you're going to have this horrible death. So as biomedical engineers, do y'all have a solution? Let me give you one possible solution, and we can talk about whether it's appropriate or inappropriate. Just think about this. What if everybody that had Huntington's disease got tested? 100%, not 5%. Okay? And you're going to marry Andre, and y'all want to have children. So she has a mom that has Huntington's, okay? She goes on ahead. She said she wanted to be tested. She wanted to know. Okay? She knows she's got it. Okay? Which makes some interesting issues, with marriage and all that stuff. But he loves you so much that he's going to marry you. He's madly in love, and y'all are going to get married, and y'all decide you want to have a family. Now what do you do?
Yeah, adopt.
Maybe. Okay. But you want to have your own genetic children.
Can't you pre-screen the embryos?
What?
Can't you pre-screen the embryos?
Exactly. So they get together with OB-GYN doctor, and they do in vitro fertilization. So basically Andre's sperm or eggs test. So you can take the embryo at 8 cells, you take 1 cell out, doesn't hurt the embryo. So typically when you do this, you have several, okay? So you maybe have 8 or 10 of them. And you can test that 1 cell if it has the gene, okay? So half of these embryos are going to be defective and half are going to be good. So you discard the bad ones, the ones that have the genetic defect, and you take the other 4 that are absolutely normal and implant those in Pauline's uterus, and she has a normal child. What do you think about that?
Pretty good.
Expensive.
All right. Y'all ready for the ceremony? Okay. Well, those are some ethical issues, though, that you really, really need to kind of think about, because we as biomedical engineers have created the technology that actually would allow this disease to be totally eradicated in 1 generation.
How much would it cost, though?
There is the problem, okay? So in vitro fertilization, you're looking at $10,000 minimum. Isn't always successful the first time, okay? So, in a very rich, developed country, it absolutely would work. But in poor country, how are you going to implement something like this? These are one of the challenges of delivering health care. Okay, I only got a few minutes, but anyway, athetosis are very slow. Unlike the choreiform movements, which are like this, athetosis is really slow, like this. Really kind of, excruciating, like, it's kind of, like this. Those are athetoid movements, okay? Y'all see the difference between choreiform and athetoid? Okay, this is caused by cerebral palsy, primarily. So, what causes cerebral palsy? Bad birthing. We talked about that. Remember that there is no more critical time in your life than when you're passing through that birth canal. Okay, that is absolutely critical. You just absolutely have to have the pump, the passenger, and the passage all working together, right? And you got to get it done quickly. Okay, so you have a bad labor, baby doesn't get enough oxygen, and what happens? Well, guess what? You end up killing the cells that are in the part of your brain, in the basal ganglia, primarily the putamen. And poor baby has this, cerebral palsy that they have to live with the rest of their life. Now, I know y'all have seen somebody with, this is very common. In a wheelchair, you've seen somebody in a wheelchair that has the motor problems, right? You know exactly what I'm talking about. That's bad labor and delivery, okay? And how do you fix that? How do you prevent it? It's a preventable problem. It's not a genetic problem. It's bad what? It's bad labor. So prenatal care, getting good care. If everybody that had a bad labor, if they had a C-section, you wouldn't have this. This would be a non-existent disease. The other way you can get it is with neonatal jaundice. So it turns out that, when baby's born, when you were little, when you were a day old, you got put under a UV light. Did you know that? To help get rid of the bilirubin in your blood, because early on, your albumin can't bind the bilirubin, so you have a high bilirubin level. It crosses the blood-brain barrier. It poisons the putamen. Okay, so it's really important when you have your baby, either take the baby outside, get sunlight. That helps to get rid of the bilirubin. Or, if you're not doing that, well then put the baby under a UV light. You go over to any of the nurseries here in town, you'll see a bunch of babies under the UV light getting rid of the bilirubin. Y'all know what I'm talking about? Y'all been to a nursery? No?
I was little.
Yeah, when you were little, I'll bet you had that happen. You just don't remember it. Okay, the last one is hemibolismus. This affects only half of your body, and these are very, very, movements like this. These are ballistic movements, and you got your arm and your leg doing like this. Okay? Hemibolismus. Okay? And so we know that this occurs because of hemorrhage in the subthalamic nucleus, and typically this is caused by a stroke. Okay, so the way to prevent this is by controlling blood pressure and all the other things that help to control and prevent hemorrhagic stroke. Any questions? That's all you need to know about the extrapyramidal system.